Hello, everyone. My name is Michael Berry. I am the director of the UCLA Center for Chinese Studies and a professor of Asian languages and cultures. And it's my great pleasure to be hosting this event and be able to be introducing our speakers tonight. We actually, way back in February, on February 10th, the Center for Chinese Studies co-hosted an event with the School of Public Health at UCLA, which was probably one of the earliest events on the coronavirus in the United States, an academic forum. And one of my guests for that event and a participant and actually kind of our co-conspirator who helped put the whole thing together was Professor Roger Detels, who is a distinguished research professor of epidemiology and infectious diseases at UCLA. He is also the director of the multi-center AIDS cohort study. And he is Dean Emeritus of the UCLA School of Public Health. And Roger's been a great supporter of the Center for Chinese Studies for many years. And I'm so happy that he's agreed to join us tonight as a kind of moderator and discussant. But his first duty is going to be to introduce our wonderful speaker. And so I'm going to turn it over to Professor Detels to introduce Professor Wu, who will be the main speaker tonight.
Thank you, Professor Berry. Professor Wu has worked in the field of HIV/AIDS for over 30 years and has published over 450 academic papers. He was the architect and the longtime director of the very successful China AIDS Control Program. He has received many honors, including the 2005 International Rolston Award for implementing harm reduction in China. He was elected to the Hall of Fame by the Fielding School of Public Health at UCLA, and he's received the prestigious UNAIDS Gold Medal in 2008 and has received innumerable awards from the government of China. Relevant to today's talk, Dr. Wu has also actively involved in China's successful response to the SARS-CoV-1 epidemic, which occurred in 2003, and he is now playing a leading role in China's response to the SARS-CoV-2 epidemic in China. And so he can give you firsthand knowledge of how to go about confronting a disease that was totally unknown 5 months ago. So I should also say that Professor Wu is a graduate of UCLA, and we're more than a little proud of him. So, Zunyou?
Thank you for your introduction, and also thank Dr. Berry for organizing this online lecture. So it's a great pleasure to join you. I'm going to use my PowerPoint slides. Let me see. So what I'm going to talk, it's a prevention of COVID-19 from a public health perspective in China. So let's go back to review early events. So in last December 30th, the first epidemiological alert was raised by local Wuhan Health Authority. Second day, National Health Commission and China CDC immediately sent an investigation team to local help make the investigation. The early cases had common exposure that were unsafe for the market. The market was closed immediately the following day on January 1st. Even we do not know what caused the pneumonia, we immediately reported to WHO and other countries, including United States. We informed them that it's an unusual epidemic. We do not know what's the pathogen yet. The common symptom is pneumonia. On January 7th, coronavirus was isolated and identified as a pathogen for this epidemic. On January 10th, we had virus sequence shared with WHO and other countries. That sequence sharing is very important for other countries to make diagnostic kits. On January 11th, the first PCR tested kit was sent to Wuhan for clinical diagnosis. On January 20th, COVID-19 was added to notifiable disease. It's required by law for all the doctors need to report cases diagnosed with COVID-19. 3 days later, Wuhan city was shut down. In the following days, another 15 cities in Hubei was shut down. So review these early events, we responded very quickly. It only took 7 days to identify pathogen. It only took 4 days to develop test kits. The early scientific funding is critically important to respond to the epidemic. The key findings include identify virus as a pathogen for the epidemic. We developed test kits for diagnosis. We identify incubation period for COVID-19. We also identified transmission mode. All of this together are very important scientific base for develop control strategy for China as well for the rest of the world. So this slide shows the epidemic curve occurred in the China in the early epidemic, particularly around Wuhan shutdown. Large number of COVID-19 cases could not be admitted to the hospital. 2 bottlenecks in the early epidemic. One is hospital bed. Many patients cannot be admitted to the hospital. They either stay in the clinic, crowded in the clinic, or stay at home. That caused rapid transmission among patients and in the community. The second bottleneck is the capability to provide PCR tests for patients waiting for diagnosis. The common symptoms of COVID-19 in the China include fever, dry cough, fatigue. That are most common 3 symptoms. And we also observed clinical diagnosis of cases with mild or moderate case, severe or critical case. For critical case, commonly observed among patients have medical conditions such as hypertension, diabetes, cardiovascular disease, lung disease, or kidney disease. This dynamic change of the clinical diagnosis or symptoms. On the onset of illness, patient may be milder or moderate or severe or critical. So most of them recover, some become severe. So without reasonable care, some moderate or mild cases become severe or critical, some may die. Based on the early assessment, we have 3 key insights based on the epidemic in the China. The first look at transmission dynamic. So the close contact was the major epidemic transmission mode in the China. So we observed the majority are close contact of diagnosis cases. So family cluster account for majority. Secondary attack rates, it was about 10% in the early outbreak and reduced to 3% with faster isolation of cases from a community. Transmission in the closed setting is happening, but it's not a major driver in the China. And transmission in the school has not been observed. That it's simply because during the epidemic season, so most of schools are closed. So far, even today, we only have a small proportion of school opened. Most are take online class. So most of school were opening in the early June. The second, natural history. So at diagnosis, approximate 80% are mild or moderate, 15 were severe, 5% were critical. Approximate 10 to 15% of mild or moderate case become severe. Approximate 15 to 20% severe become critical. In terms of average time from exposure to onset of symptom was 5 to 6 days. Average time from symptom onset to recovery for mild cases is about 2 weeks. For severe cases, it's 3 to 6 weeks. Average time from onset of symptom to death, it's 2 to 8 weeks. Truly asymptomatic infection is unknown without a serological study. So in the initial early, our estimation about less than 1% in terms of prevalence. We are now doing nationwide serological survey. The study is ongoing. We have collected a specimen. Laboratory testing just finished. We are now doing data analysis. The final result will be issued to the public very soon. Children tend to be milder disease than the adult. So we did analysis. The milder or moderate case account for over 90% among children aged less than 18 years. Number 3, virology. Virus shedding is highest earlier in the course of disease. So what we identify for virus shedding, it starts about 1 to 2 days prior to symptom onset. That is very important for the public health prevention message. So I still remember in the CROID meeting, I made a presentation. I remind, because this virus shedding is different from SARS, the public wear mask is very important to stop transmission. The virus can isolate it from a stool, but there's no epidemiological evidence for fecal oral transmission yet. Virus shedding usually continues for 7 to 12 days in the mild and moderate case, could be more than 2 weeks in the severe cases. Patients who recover can be PCR positive after symptom resolve. We still observe some of patients PCR positive, even they diagnosed as COVID-19 in February. So we do not understand, is that continuing shedding virus or they have reinfected? We are still carry out a study to understand. So China uses fundamental public health measures to contain the epidemic, that including universal population measures. Everybody wear mask and hand washing and keep distancing. The second, case isolation and management. That's very important to quickly identify cases and isolate them from a community in order to reduce transmission in the community. Number 3, close contact quarantine. So for all the diagnosis cases, we make immediately epidemiological investigation, identify close contactors. All the close contactors need to be quarantined for 14 days, either at home in the early stage. Finally, all the close contactors put in the designated hotel for quarantine. The number 4, suspension of public gathering. The number 5, movement restriction. Let's look at the magnitude of these public health measures in numbers. Nationwide, we have 1.4 billion people underwent at least 10 days at home isolation or quarantine. So that is very important to separate the suspected people with infected people. That is very powerful to stop transmission. Look at the Hubei province. We have a total 59.2 million people subject to control sanitaire for 2 months. For Wuhan city, we have over 10 million people shut down for 76 days. The hospital bed, in the early epidemic, there were only about 2,000 hospital beds for infectious disease. The hospital bed increased sharply, quickly to over 50,000. That including building new hospitals and 16 temporal module hospital or shared hospital. Health workers were overloaded, and we have over 40,000 health providers deployed to Hubei to provide assistance. That is critically important to reduce workload for local health workers. That also have to reduce the infection among health providers. So we made differentiation of level for cases and provide different care and isolation. In terms of category, we have total of 5 close contactors, suspected cases, mild or moderate case, severe case, and critical case. For close contactors, our strategy is quarantine either at home or in the hotel. The early experience tells us home quarantine is not the best because at home, they cannot really perform quarantine. They still have contact with family members, still have family transmission. Then we changed our policy. All the close contactors must be put in the hotel for quarantine in order to reduce the transmission because close contactor may be already infected, just have be pre-symptomatic stage. For suspected cases, usually put general hospital. We also made a mistake in the earlier. Suspected cases, some may infected, some may not infected. They does not have the laboratory confirmed yet. They are waiting for laboratory confirmation. So if put the suspected cases in the same ward, that may also create transmission among suspected cases. So suspected cases must be put individual ward in the hospital, cannot be put in the same ward. For mild and moderate case, this majority accounted for 80% of diagnosis cases. They have night symptoms. They do not need sophisticated care. So they were put in the Fangcang shared hospital. Severe and critical case, they must be put in the general hospital or designated sophisticated or advanced care hospital. So I want to use a few slides to highlight shared hospital. That's critical important public health measures to contain the epidemic. The shared hospital has 5 basic functions. First, isolation. That's critical important. Put a patient in the shared hospital, isolate them from the community, and reduce transmission in the community. That's critical important to stop epidemic. Second, triage. So patients in the shared hospital are mild or moderate. They may become severe, they need to be referred to the designated hospital. So that's critical important for triage. Number 3, basic supportive medical care. The number 4, daily monitoring, rapid referral. Number 5, essential living, accommodation, and social engagement. So services provided at the Fangcang Shadow Hospital including following: monitoring, body temperature, blood oxygen saturation, and blood pressure are monitored 3 times a day. Number 2, medications. Antiviral therapy, aerosol inhalation are provided to patients. Number 3, counseling. Counseling will provide to patients that experience fear, anxiety, panic. Number 4, exercise. Square dancing and Tai Chi are 2 common exercises. It's implemented 2 times per day. That's very important for a patient to be engaged in the shadow hospital. The number 5, transfer. If mild or moderate patient condition become worse, they will be immediately transferred to the designated hospitals. The number 6, discharge. When clinical symptoms or CT image become abnormality has resolved or more, and also 2 negative PCR test results, then patient will be discharged from a shadow hospital. They will continue to be observed for 2 weeks in the community or at home. Here are examples of activity in the shadow hospital. In the left side, a patient taking oxygen. In the middle, it's health workers to monitor patient's symptom. The right side, it has provider training the patient how to do hand washing. This slide shows the change of Fangcang Shadow Hospital. So in the the dark blue, it's the number of patients discharged. In the light blue, it's the number of shadow hospital bed being used for the patients. So in the light red, is the number of patients in the shadow hospital were referred to hospitals for advanced care. The red bar shows the number of patients discharged cumulatively from a shadow hospital. So there are 3 advantages and 2 disadvantages. Shadow hospital can be rapidly constructed just to build a shadow hospital. It'll be massive scale. The hospital bed capacity could be in the thousands, provided to the patient just 2 to 3 days. The low cost, it only require small number of health workers to provide care to large number of patients. 2 disadvantage. The privacy cannot be guaranteed and not easy to meet individual demands in such shadow hospital. So now update epidemic of COVID-19 in China. By May 15, just a week ago, we have total cumulative 82,933 total reported cases, and we have total cumulative deaths 4,633 that already included over 1,000 underreported cases emitted a few weeks ago from Wuhan. The total cold case fatality ratio was 5.59%. Now the epidemic in China, majority are imported cases. So you can see the red bar. So the red color is imported cases. The overall number is very small. So we interpret the epidemic, it's almost ended now. So our emphasize to prevent importation and possible second wave. To review the epidemic and the response, we have 8 lessons summarized. The first, science-driven response. As I presented in the first slides, in the early response, we quickly have 4 scientific findings that is critically important for developing a control strategy. The number 2, core traditional public health measures played a significant role in the control of the epidemic, that including wearing mask, hand washing, social distancing, and ventilation for the fresh air. All of these are critically important. The number 3, critical bottleneck being solved in the early stage. That was hospital bed and PCR test. The number 4, community mobilization and community response. That's critical important. We call the people's war. It's for the people, by the people, all the population mobilized. The number 5, transparent public communication. So we are transparent in the early stage. Even we do not know the pathogen for the epidemic, we informed WHO and other countries. We communicate with the world the potential emerging epidemic occurred in the Wuhan. Then we will report with our new development. The number 6, international cooperation. The number 7, leadership, coordination, and cooperation. The number 8, logistic support. In terms of key experience, we developed 4 defense lines as a strategy. The first defense line was Wuhan and Hubei. The second defense line was Beijing. The third defense line, Hubei surrounding regions. The 4th defense line was nationwide. So that prioritized our resource location and our focus. For earlier, that important for identify cases and isolate the cases from a community. Early detection, early reporting, early isolation, and early treatment. For the people, by the people, we have community engagement, community health education, and community hygiene and disinfection. 3 C's, another 3 C's, coordination, cooperation, and communication. Resource allocation is critical important, that including healthcare workers and PPE equipment, logistical support, and public understanding, and infodemic response. We're continuing develop and revise our technical guidelines. In terms of diagnostic and treatment protocol, we have a total revision of 7 additions. For the prevention, we have 6 additions already issued. We are now in the stage develop or revise 7th edition for prevention and control protocol. All of this protocol are updated based on the new knowledge we acquired. Now, in terms of control the epidemic and also to prevent possible second wave epidemic, we timely make a risk assessment for the community. For low risk area, the priority is to prevent importation. For medium risk area, to prevent importation and stop local transmission. For high risk area, stop local transmission, prevent exportation, and implement strict prevention and control measures. All of these risk assessment and strategy is adjusted based on change over time of the epidemic. For case management, so we have the different category of cases and we have different strategy. For suspected cases should be isolated in the single room. Cannot put 2 suspected cases in the same room. confirmed cases and asymptomatic infection could be isolated in the same room, such as in the shadow hospital. For discharged cases, will be given isolation and health monitor for another 14 days in the community or at home. We encourage follow-up observation and respiratory specimen testing. For asymptomatic infections, cases are asymptomatic, need to be isolated and put in the medical observation for 14 days. If they become symptomatic, they are transferred to the hospital. If they continue to be asymptomatic, they will be discharged when they have 2 PCR negative. For close contact of asymptomatic cases, they will be treated as close contact of symptomatic infection. Any person who have close contact with asymptomatic cases need to be take a specimen for 2 days. And medical observation will be put for the close contact at a designated places, such as a hotel. For contact tracing, so for all asymptomatic cases or symptomatic cases, we will do investigation, epidemiological investigation, try to identify their close contact. That's critical important. So we use multiple strategy help to identify close contactors. So we have multiple department cooperation assist to making sure we can identify as many as quickly as fully as contacts as possible. We try to identify all the close contactors and making sure close contactors are put in the quarantine. Close contact put in the quarantine either at home or designated places. In the early stage, we encourage home quarantine. Later on, we change the policy. All the close contacts must be in the hotel for quarantine for 14 days. Their temperature and the symptoms are monitored twice a day. No outdoor activity is allowed. Daily living allowances are supplied by local community. That's very important for the community support to provide logistical support for people in the quarantine. So earlier, we are too optimistic. We interpret the epidemic may be like SARS will go away. However, it seems that we will live with virus for a long time. So now we have to develop the long-term strategy to dance with the virus. For the long-term strategy, we need to prevent importation of cases and to prevent community resurgence of epidemic. So we have control strategy for imported cases. We have tailored control measures for the community risk assessment and strategy. The early strategy will modify and strengthen in the changed situation. So we strengthen case reporting and surveillance, enhance laboratory testing capacity in the county level. We maintain graded community prevention and control measures. Resume production and work, prevention and control protocol at various risk levels. We'll explain one by one. First, control strategy for imported case. We have created low gap chain from a border to community to home. For traveler coming back to China, so in the entry point, we have screening. Screening will request traveler reporting the past 14 days history, health status. We have temperature screening at entry point. Patient will be categorized as confirmed case or suspected case or close contactor. We have medical examination provided for suspected symptoms. Confirmed case or suspected case at the entry point will be transferred to designated hospital. Close contactors will be put in the designated hotel for quarantine. Quarantine is required for 2 weeks for the travelers, regardless it's a domestic or foreigners. So earlier or active detection cases is implemented. We use 5 strategies to promote early detection of cases. So health facility at all levels were alert for implementing early case identification. We use existing surveillance network to identify early cases. We have health status monitoring of close contactors. We have port health quarantine for imported case detection. At primary level organization and employment and employer, they will have the health check for all the employee. All of these 5 strategies combined together will help us to identify cases in the early stage. We also have specific prevention measures for the zone of economic. We create the health code and the travel card for people traveling without restriction. We also created point-to-point labor cooperation. That means organized migrant workers return to home point by point. They direct transfer migrant work from their home to the manufacturer designated cities. We also created the prevention control guidelines for work resume in the enterprises. Now, the control called normalize of prevention, not emergency. So normalize response in order to prevent a second wave. For the daily, for most of the people, for the daily practice, we including the following 4 strategies: mask wearing, social distancing, ventilation and disinfection, and health habits. All of these 4 strategies are implemented nationwide, and for all the Chinese people, it's massive, it's universal. Then we have the strategy for disease control and prevention. We have also 4 strategies: early detection, temperature screening in the public places, and triage at outpatients and fever clinic, early investigation, and precisely control. That means now we have more precisely identify community or unit for implementing strict control measures. Once we have the new cases, not whole community, we may only have a board or a building limited as infectious. The number 4, early treatment. We identified the key places, key institute as a priority for prevention. So with fully reopening living places, so in the following places, it's a fully reopening: shopping malls, supermarkets, hotels, restaurants, all of these without any restriction, as long as they implementing 4 strategy for the general public, like mask wearing. The second category is conditional reopening indoor public places, that including the public parks, sanitary supports, sports venues, libraries, museums, galleries, movie theaters. So all of these are reopening conditional and also have limited personal flow. Prevention measures for key institutes that include hospitals, schools, pension institutions, mobile homes. So based on that category, so we have different opening strategy with prevention control strategy to assist. Then we identify key populations and medical institutions for prevention and control with new normal life. For the vulnerable population, we identified elderly people, children, pregnant women, disabled people, patients with severe chronic diseases, and also have personnel protection, mental health support, daily living support for this vulnerable population. For the medical institute, the strategy included strengthen nosocomial infection control, strictly implement requirements of district management, strict visit and management accompany care to avoid a cross-infection. All of the strategies are implemented in medical settings because we observe a lot of cluster transmission occurred in the medical settings. In the China, we have two clusters. One is in the hospital settings, other in the family setting. So this cluster setting is critically important in the medical settings. School setting and communities. So schools is the one of highest risk group in the community. So for the school, we have health monitoring that we have daily report of no symptoms. They need to report, zero reporting. In the morning, afternoon, exam of enrollment, and we have registration and management of absence due to illness. If a patient, if a student or teachers report they have absence, they need to report what illness. In the community, we have a grassroots community management, try to identify cases in the early stage. So community support in China is very, very strong. In order to support the strategy I reported, we have technical support that include the following. So testing reagent and assay equipment and research and development, try to provide the technical support for implementing prevention. One of very important is testing. Now in China, we called testing should provide it to as much as possible for key populations. The key populations that include close contactors or overseas returnee and patient at fever clinic, newly admitted patient, and in the port quarantine. All of these identified as key. And now in China, in the Wuhan city, is a massive PCR screening for the general public in Wuhan. Almost everybody in the Wuhan will be tested in the next 10 days. Also, testing are provided to people who are willing to be tested for other population. If people volunteer, I want to be tested, they can be offered for PCR test. PCR test is very cheap. Now in China, it costs only about less than $10 per test. All the tests now is free. key population are free. It's only people volunteer to be tested that will be paid by either institute, by individual themselves. The cost is affordable and accessible as well. That's the end of my slide presentation. Thank you for your attention. If you have any questions or interest, we could discuss.
Thank you, Zunyou. That was certainly an exhaustive presentation, and it's very impressive how thorough it is. It's really hard to ask questions. One couple of questions come to mind. I think one of the issues that is not settled as yet is what proportion of cases are actually asymptomatic, and whether asymptomatic cases can in fact transmit disease. So I wondered how you plan to identify asymptomatic cases. It would appear that in Wuhan, where you're testing everybody, you'll find them, or at least you'll find them for that moment in time. But over the long run, what sort of strategies would you recommend for identifying those who are asymptomatic through a surveillance program or other strategy?
Thank you for that question. Very important, critically important in terms to prevent the possible cluster transmission or epidemic. Actually, we do have data even in the early stage. In China, we implemented the close contact isolation or quarantine. So in the close contactors, particularly in the Guangdong province, they tested over 10 million close contactor. So by testing close contactor, they identify cases, they are PCR positive without symptom. So that has actually two categories. Some of in the pre-symptom stage, when you continue observe, they may become symptomatic, and some will remain asymptomatic. So we look at that proportion. So among all identified PCR positive at this stage, between there for another 2 weeks, about one third, less than 1/3, remain asymptomatic. Majority, about 2/3, will become symptomatic. So that's one of the data we have. Also, we have serological study that is ongoing. That study may have some potential issue of false positive. Given the true prevalence is very low in China, we do not have the community transmission. So it's only in the Wuhan, we have community transmission in some community. In the majority of China, we only have a cluster transmission in the hospital setting and in the family settings. So in terms of transmission, we do observe. So with close contact of cases, they are even in the pre-asymptomatic. So then we can categorize close contact of confirmed cases, close contact of asymptomatic cases. Then we observe which proportion become infected. Asymptomatic cases have a lower secondary rate, and also the reproductive number, basic reproductive number is smaller compared with confirmed cases. However, because asymptomatic cases, they are not easy to be identified. They become potential risk for possible second wave or for the epidemic.
So I guess the only point I'd make in terms of your response, I think if I heard you correctly, you said 1/3 would be asymptomatic.
Right.
I would say that 1/3 of 1.4 billion people is not so small. That 1/3 strikes me as a fairly high proportion of asymptomatic. I don't know of other diseases. Well, polio would be that high, I guess.
No, No, I think maybe I expressed not clearly. I'm talking about 1/3. It means among people get virus. It's not a population. It's among the denominator were cases identified PCR positive. Among PCR positive, 1/3 are symptomatic.
Okay, I'll have to think about that one for a while, but I'll come back at you in the next couple of weeks. And the other question I have is that in the United States now, what's going on is that we are opening up. And stores are opening up, and restaurants, et cetera. And I think it's pretty impressive that you've gone through an opening up situation. You've been opened up in Wuhan for what, about 3 weeks now?
We start. It's more than 1 month now.
Is it
so
1 month?
We reopened April 4th, April 8th.
Oh, okay. Well, I think what's impressive, that's even more impressive, because that's enough time for several incubation periods to have transpired.
Right.
And it's my impression that you have not had a resurgence.
That's correct. That's correct.
So you've taken very dramatic steps to keep the population under monitoring. You've been in the United States. You were a student here. You sort of know how we operate in the United States. Are there lessons from China that would be feasible for the United States as we attempt to open up? Tough question.
I think it's a different situation. In China, after strict implementation of strategy, we almost no community cases, except a few in Han and reported cases generate. So given that, still, for example, it's like in the early epidemic stage, so it's manageable. It's manageable. The difference in the United States, you have many uncontrolled cases. So they become reservoir or transmitter in the community. So that's very difficult. I think another issue is the culture difference. So in China, so the general public follows what we were told. So even like we have the contact center shut down, it's the whole country suddenly stopped. That policy is very hard to be implemented in the European countries, in the Americans. So because people are more individualized, people are more prioritize their individual rights. So in China, we do have the community probably put the top priority rather than the individual rights. So that's a different culture. And in terms of mask, we believe masks are important. So everybody follows the instruction, wear the mask. However, that takes a long time for Americans to wear masks. So all of this culture difference.
We still have one person who will not wear a mask.
Yeah, even you have like visit to the hospital, they do not wear a mask. Your vice president.
Yeah, I agree with you. I think through the years that I've worked with you and other people in China is that the American culture is a culture of individualism, whereas I think the average Chinese thinks of himself first as a member of a community, and then as a member of a family, and then as an individual, whereas it would be just the reverse in the American culture. But I defer to Dr. Berry because you're the expert on China.
No, there certainly are very powerful cultural differences in terms of how each of our nations have responded. And in some cases, that has worked to China's benefit and to our detriment in terms of this notion of individuality and people. If you look at American news and you see people protesting the quarantine, um, that's directly derived from this American notion, right, of individual freedom and no one's going to hamper my individual rights. But it's also going directly against the science and what we know about how, nobody's happier about those protests than the virus itself, I'm sure. If I could jump in for a question, and this may be for both Professor Wu and Professor Detels. You're both experts in this field of infectious disease and epidemiology. You've had many decades of experience seeing other viruses come and go. I know that neither of you have a crystal ball, but what's your best, looking forward, everyone I think is eager to, not just when we can open up, but is it going to recur in the fall? Is it going to recur in the winter? Is it going to be 2 years, 5 years? What's your best guess looking forward as to the macro trajectory of this virus and what we're in for long term?
I think the problem is that the standard answer is we don't know. We know how respiratory transmitted viruses behave. The coronavirus, the SARS-CoV-2, isn't behaving like the typical respiratory virus. And you have a population that basically has zero immunity. And so there's a great concentration of susceptibles. I think I agree with Professor Fauci that we're likely to see ongoing transmission, hopefully at a somewhat lower rate, as some of these interventions hopefully take effect. I think ultimately, hopefully, we'll get a vaccine. And while it appears that the immunity that is associated with the coronavirus's infection is transient and only lasts for a year or a year and a half at most, this would put us into the same situation we have with influenza, where we just get a new influenza shot each year. With SARS, we would have to get a booster shot every year. So I think that would be the most optimistic scenario, but it does depend on coming up with a good vaccine. So Zunyou, what's your reading?
I think it's not called reoccurring. So the epidemic has not gone yet. It's continuing. So still globally, the epidemic is continuing. Even in China, if we do not implementing active response, so the epidemic may just take off very quickly. So the question is how that this epidemic continue for how long. So that depends on how quickly we can develop effective vaccine. So the good news, it's just yesterday or before yesterday, a new article published in the Lancet. The vaccine trial, the clinical phase 1 or phase 2 in China has demonstrated a very good response. So that's a good sign. So hopefully we will have a scientific movement quickly, have effective vaccine be ready for vaccination. So without vaccine, so the world will totally change our lifestyle. So it's uncertain, very hard to make a prediction. So it's definitely the virus cannot go away easily.
You've basically got two experts agreeing on something.
I would like to ask one more question. This is jumping off Professor Detels' earlier question about the American response and the difference between what's happening in China and America. And I'm wondering, Dr. Wu, given you have so much more experience and a head start on seeing this through in China and having at least a couple more months than what we've dealt with here, I want to push that question a little further and ask, hypothetically, if you were heading the United States CDC, what would you do right now that's different than how it's being handled? What would you strongly recommend be done in terms of the current response?
So I think most important is to analyze the weakness. So we need to identify the possible weakness. So need to, from epidemiological point of view, to analyze the data. So who are most at risk of infection, who are most put others in risk. So look at all the prevention measures which are not implemented appropriately, which has not been implemented. So that's critical important. In China, what our strength is the data. So we have 5 data systems. We work day and night to collecting data. We analyze the data daily, identify where is the source of infection, where it's the top priority, need our resources to focus. That daily analysis, data-driven response is critically important to inform policy, to inform implementation activity. So look at the data now in the United States. I think Johns Hopkins play a leading role inform the world the epidemic, not the CDC now. So that it's very strange.
I think the other point that I would make, over the years, Zunyou and I have worked on many different projects. And the one thing that I've discovered through those, much of the work that Zunyou and I have done has informed policy. And as a result, it's very interesting that we will do a research project which has policy implications. That policy is often implemented within months of when we've made the observation. That is not the case in the United States, where China really does have evidence-based medicine, as Zunyou likes to say, whereas we tend to get it politicized in the process. So, Zunyou, would you like to add something to that?
Yeah, I think that's very important to translate the scientific finding immediately to the policy. So that's a very good advantage in the China, as long as we demonstrate it works. So could it be just 1 month become a national policy quickly implemented? Over.
That's what makes it exciting about working in China.
Thank you.
Professor Detels, do you have maybe a final question for our forum?
No, I think we've asked most of them. We've pretty well explored the issue. I would like to thank Zunyou. As usual, Zunyou, it was an exhaustive presentation. You got all the I's dotted and all the T's crossed, and you didn't leave much room for questions. So I commend you on that. But I think it's also reflecting of China and China's rapid response. I'd like to emphasize as we close that the interval between the time that China first began to realize that they were seeing something that had not seen before, which was about the 21st, 22nd of December, to the time that they had identified the positive organism and developed the test, was 2 to 3 weeks. And within 4 to 5 weeks, they had implemented an intervention strategy, which appears to have worked. So I like to underscore, I don't know of any other disease, any other emerging disease that had a timeline that was that short. I don't know. Zunyou, do you know of any other? I don't.
No. I think that creates a history record.
Yeah.
Yes. Well, thank you, Professor Detels, for helping arrange this talk and for chairing it and moderating it. And thank you especially, Dr. Wu, for the wonderfully informative presentation, but even more so for all of the hard work you're doing at the China CDC. And we really appreciate you sharing your experience with us today.
I might say, Zunyou, that Mimi enjoyed your presentation. She's right over my shoulder.
Yeah, I saw her. Yeah, just pass my regard to her. Stay healthy.
Indeed.
Yeah.
Thank you.
Okay, bye-bye. 谢谢你。
Really? Hello.